Good morning to everybody. The peace of the Lord be with all of us.
And with you.
Thank you. Now I feel peaceful. Okay. So we are very glad that we're able to organize this. There's a team that actually put this together. And we are very thankful to Dato, Dr. Amar Singh, who has indicated his willingness to come and share with us this morning. Dr. Amar is married to Dr. Sui Im Lim, and Mrs. Amar is also in the session today, in the webinar today. We welcome her as well. Can we put our hands together to welcome both of them without any noise? Okay. Welcome. Thank you so much for joining us. Thank you for being with us to speak to us. Dr. Amar was a senior consultant, senior consultant community pediatrician at Hospital Ipoh before he retired in the year 2018. Of course, we all know retirement is retirement. After that, we are all reused in so many ways. We make ourselves available, and we are very thankful that Dr. Amar has continued to be active, right? And he is doing a lot of things. If I say all of that, it is going to take a lot of time, right? But we are glad that he is actively serving in so many ways. And many of us have come through his YouTube messages, his writings, and so on every now and then. But now we get to see the man himself, right? And to hear him. He has also, he's actually an active child advocate, and he's a recipient of the Outstanding Asian Pediatric Award, right? So we are very proud of all his achievements, right? And he's here today, as Dr. Swimming told us. He will share with us on the COVID situation in Malaysia today. Of course, most of us, we are monitoring this, right? But there may be some gaps in our understanding some of these things. So we pray, we understand a little bit more today and arrive at better conclusions, therefore, and more importantly, as to what the church can do. What is the church's response? Of course, at the moment, I can say to you, for instance, the church in the Methodist Church, and of course, the church in Malaysia as a whole, the Methodist Church especially, we have been raising funds, trying to help people, not only within Malaysia, but also overseas. We have sent money overseas and so on. But is there more that we can do? We have also, most of us, closed our churches, right? And we are doing live streaming services and so on, to all of these to help us. Okay. Even our HQ, there's nobody here. I am here alone. Okay, so we do whatever we can to minimize movement, to keep people at home, right? Here in the office, we have told everyone strictly they must all stay at home. Okay, but I stay next door to the office, so I'm here, right? So we do our best, but what else can we do? So that's something we can talk about today. There are a number of other efforts as well. Churches coming together, not concerned about our denominations and so on, but we're also coming together to work together to help in so many different ways. And I'm sure you are hearing about that as well. But this morning, let's prepare our hearts and our minds to hear and be blessed. Right? Let me begin with prayer. Let's pray. Father, we want to give you praise and thanks for this morning. There are many of us who are interested to know what's going on, and we want to be able to play our part to improve on the situation in this country, Lord. Many people have been affected by COVID-19, some directly, some indirectly. Some have lost their loved ones. Others, their loved ones are still in critical stages, struggling. Even some others who are being quarantined at different phases. And different one of our states, our districts are in different phases, different situations that we are faced with. Economically, people have been affected. Health-wise affected. Socially, emotionally affected. So we ask and pray, gracious God, for you to look upon us mercifully. Be merciful to Malaysia. Be merciful to the whole world, we pray. Look favorably upon all of us. Please look favorably upon your creation. This morning, as we set our hearts to hear Dato Dr. Amar Singh share with us things that we should know and his concerns as well. We pray, gracious God, that we may be able to receive what is said, process through, and do our part respectively. We give you thanks and commit this time to you. We pray that the Zoom session will go on well without any disruption whatsoever, that we may be blessed at this time. In the name of Jesus Christ, our Lord, we ask of you. Amen.
Amen.
Dato Dr. Amar, over to you.
Thank you very much, Bishop. And please, everyone, just call me Amar is fine. Okay, that's the way to we can work. And I want to thank Siu Ming and others who organized this. I noticed that even one of my school teachers is in the audience, probably came to monitor me, and it's a delight to meet her. And I also noticed some old friends in the chat room as well. Now, I come to you in the grace of our Lord Jesus Christ, in the fellowship of the indwelling Holy Spirit, and in the eternal love of our Father. I think that's how I come. I think we all are very humbled at this time, what this virus has done to us. I think it's brought all of us to our knees. And as Bishop said, I pray for your discernment this morning, that you will take away what you need to from God, not what I'm saying, but what God needs for you to hear. Now, since there are translations that are going to be in Bahasa, Chinese, and Tamil, I'm going to speak slower than I normally do. I'm going to try and emphasize some points because their key role is to communicate the points. As has been shared earlier, there are two documents available to you. One is a document outlining much of what I'm going to say today, focusing on what we can do. The second one is a document on children and vaccination. I recently was asked to put together a session on that, and I don't like just to talk, like to give notes that you can take back and reflect on. So consider that because I think that's also a topical issue. I'm going to share screen right now with you and show you some slides and use that. So I'm going to be factual with you. I'm going to talk with the data. And if I give any opinions, I'll let you know that they are my opinions and talk about how we can take action. Again, as I said, there are two files, and this QR code takes you to one of the files, but there are links for both files given earlier. Now, there's important caveats when we think about COVID-19 in any country. One issue is that it's very fluid. It's very rapidly changing. Even this morning, or the last 48 hours, much of my thinking is about the Lambda variant, because that's become now an issue for us to think about. So whatever I say today, you need to recognize that it may change, new light and evidence may come, and may need to be revised tomorrow, especially the size and impact of the outbreak in Malaysia is changing all the time. Secondly, we know the data transparency is limited in Malaysia. It's always been in many countries, not just in Malaysia. And so this limits our full appreciation of what's happening in the country. And I'll try to share with you some idea of seeing past the limitations. And finally, there are lots of opinions. I notice that lots of people receive WhatsApp and Telegrams and other messages, WeChat. And I think we need to be wary with some of these. We need to follow the data and the science, the evidence. And there are lots of rumors being spreading. Every day I receive from colleagues and friends and church members, things want me to check. And sometimes they come from very, very dubious sites. And I can say, hey, don't need to listen to this site because it's well known to be a fake news site. So there's a huge volume to read. I'm blessed to belong to a number of online doctors groups and think tank groups. And so that helps me to collate the data faster and listen to my colleagues as they think together with me. Okay. So I'm going to cover these issues. What's happening to our outbreak in Malaysia? How is our health system managing and why are there so many deaths? How is the pandemic changing right now in our country, especially the last 1 or 2 months? How is our vaccination progressing? What's coming next? I wrote an article just recently about the 5th wave, and I'll share 1 or 2 ideas from there. And what can we do next? I'm not going to cover should we vaccinate our children, but I'm happy to take some questions on that in case anybody needs that. So coming to the first one, what is happening to our outbreak in Malaysia? So as a summary, Cases are still high, as you well know, but you must recognize that reported numbers don't give us the full picture. So I notice people respond every day to report, oh, now it's come down, now it's go up. My wife and I don't, and most of us doctors don't. We look at the trends that's happening. Why do we do that? Because the testing is very limited. Reported numbers depend on testing. So every day we look for testing numbers, which sadly are not shared with the public. We have to go and find this ourselves and calculate it and share ourselves. And finally, one more thing you need to keep in mind when you're looking at numbers is clusters are not the focus. I notice a lot of the information given online, even from the authorities, are focused on clusters. Don't focus on the clusters. Focus on the community spread, which is the bigger part of the pandemic. So let me illustrate all these points with you. One very, very good site I would recommend to you, in case you don't already know, is our World in Data. They're a phenomenal site run by very, very good people. They try and bring all the data in the world, not just on COVID. I've been using them for years. Very good data on poverty, insurance, stuff like that. So consider this site. So this is just a crude number taken from them, our daily cases going up and down. But the better figure to look at is this one. This looks at a 7-day average. It looks at a trend. It smoothens the curve out for 7 days. And it's look at per million people. So this way you can compare with other countries because it shows how you are doing with other countries. Today, I'm not really going to compare ourselves to other countries because I think we're not one of the better countries, one of the worst countries in the pandemic right now. So we recognize we had one wave and then a very small second wave, which some of us don't really call a wave. Then there was a third wave. Now we've finished the fourth wave, okay, muted by our MCO. MCO did a good job to bring this down. Of course, the authorities haven't called it the fourth wave yet. And then notice that we have got an up spike very quickly. I'll come back to this graph when we talk about, where we're headed. Here's another graph taking the same data, but this time what I've done is I put it into 100,000 numbers and cumulative spread over time. And I've shown how long it takes to take every 100,000 new cases report. Again, remember, these are reported cases to us. And you can see it took 1 year to get us to 100,000. But right now, it's taking us about half a month. Looking at today's data, yesterday's data, it's also going to take us another 16 days to get to the next 100,000. So right now, we're moving up by 100,000 every 15 to 16, maybe sometimes 17 days. And recognize that this means that our pandemic is moving at a very, very fast rate right now in our country. Also, when people ask me, Amar, is this the real number that we're seeing every day? Well, I tell people you probably can multiply by 4. So if you're quoted 7,000, then you probably multiply by 4. And that's probably a very conservative estimate of the real number of cases for that day. Now, don't worry about this very busy one. It's just to show you what we do. Some of us in the country are actually looking at reported numbers, then which we have to calculate, then looking at the positives and then calculate the positivity rate, which is the most important thing. And then we try and project what's happening. And so these positive rates here on the right are what you should look at. Whenever they're high, we're not in good shape. WHO says less than 5%. In fact, most people say 3% is probably the right place. If you're at 3 to 5%, you know you're testing enough. When you're past 5%, you know that your test numbers are far too little and you miss thousands of cases out there. Okay. So here's looking at the trend of our positivity over time. Somebody has nicely done this. I got this from our former health minister. His team is also monitoring like many of us. And the orange line shows you the smoothened number. And you can see that probably from about, May onwards, early May onwards, we've never come down below the 5% line. So we've actually had a very high positivity for the last, 2 months, now even this month. Yesterday's positivity was 9% plus. That's really frightening. The last 2 days has been 9%. So that's really worrying for us. And WHO leader says, you cannot fight a fire blindfolded. You can't stop this pandemic. We don't know who's infected. So test. But unfortunately, in our country, we are not following this advice. Okay. So I've converted this particular data that I showed you into a graph like this. This is the blue line of just the recent half a month of where our reported cases are. And the red line is if we actually tested even 100,000 a day, you can see where our numbers would be. We should be reporting 9,000, many days, or 8,000 at least most days. That's a number we should be based on the positivity rate that's happening every day. And if you draw a trend line, if you do some statistics, you can see that actually our pandemic is growing, not coming down. So the MCO has halted it for a very short time, and now it's growing back again, mainly because it's spreading in the community unchecked. Okay. Now, having said that about the whole country, we are trying to get granular data, which means trying to get state or district data, which is very hard to get because it's not released to us. We have no access to it. Occasionally it comes out, and this is from in middle of June, and you can see that the positive rate for different states is different. I live in Perak and we're not so bad, you know. You can see Penang has worked very hard to bring it down because they're doing mass testing, but some states are really bad. Labuan is really in bad shape, has been in bad shape for 2-3 months. KL, Selangor, Negeri Sembilan is really in bad shape. Melaka is just coming out of a bad phase. Kelantan is still in a bad phase. So if you gave this by district or by state, then you get a better appreciation of what's happening to your locality rather than the general numbers we receive every day. So I don't have any current numbers to offer you, I'm sorry. Okay. So as I said, don't look at the clusters, because even as our Director General says, 80% of our community right now is about 60 to 80% on any one day. The blue bars are the case numbers that come from clusters. The orange bars are the ones that come from what are called sporadic or community spread. See, what's happening is that when it happens in a factory, these blue bars here, they will come and test everybody in the factory. So you get you can capture everybody. You can say, okay, of this factory, 500 people, 200 were positive. That's fine. But these fellas, they just walk into hospital very ill, or they came to see the GP and they're not so well, they got tested. We are not testing their family members. We are not testing their friends. So this part is not being tested generally. Okay? It should be. WHO said this is the minimum we should do. All your contacts we should test, you know, but we are not testing. If we did this, then our test positive would come down. So this is fueling our epidemic. This community spread is what is actually the unknown one. So you never know who is positive because you don't have. And the MySejahtera app doesn't really tell us if somebody near us has been positive because that data is not shared with us. In some countries, they do that. They electronically tell you you have been in contact with a positive person. So at least you can go and test yourself. So that's the first thing, telling you about the state of our pandemic, and the numbers don't really tell us the full story. We have to start looking at test positive, and we'd like to see a lot more testing in our country and worry about community spread. The second thing is how's our health system managing? Why are there so many deaths? The reason is because you well know that our ICU beds are very full, okay? And we've now repurposed the general beds to use for ventilating people, which is not ideal, of course. A portion of our, something that you may not know, a portion of our ventilated patients in ICU are dependent. They're stuck there. They've been there for 2, 3, 4 months, some of them. They can't be taken off. They're in bad shape and they're trying to rescue them. So that in a sense clogs up, that in a sense holds up some ICU beds from being used by people who get fresh illness. So once this happens, mortality rates will go up. And of course, what is we don't know, we have no numbers at all in the country, but have been estimated by some groups internationally for us, is what are other people dying? So you had an accident, you need ICU bed, you can't get access to it. That's called non-COVID mortality. Or you're a child, you have a very bad pneumonia, but you can't get an ICU bed. I think for children, largely, our ICU beds are largely spared, so we still can offer that. But for many adults who have other illness, maybe a cancer or some other problem, normally we can salvage you. Now we can't offer you an ICU bed, and that mortality needs to be considered as well. So let me illustrate each of these points with you. So ICU beds are full. They gave us the numbers every day. These are numbers from yesterday, okay? And ICU beds are not just full in the Klang Valley, they're full in Melaka, Negeri Sembilan, Labuan. They were full in Sarawak, but I think Sarawak is just coming out of that. Perak ICU beds are going back up, you know, in number. So it fluctuates. Kelantan is still fairly full. And what we've done, we've taken all our coronary care units beds, that means that the ones who come for infarct, and changed them to ICU beds for COVID. So which again means if you have a heart attack, your care may not be optimal anymore because you might go to a general ward. Some hospitals are even taken the operation theater beds and made them into ICU beds because they're that desperate and short. And of course, we've taken the casualty beds and are ventilating people in casualty. So some people are stuck in casualty for 3-4 days trying to get into an ICU, which is very suboptimal. And finally, the least suboptimal is if you get a general ICU bed, a general ward bed, which means it's just in a general ward, they put a ventilator for you. And that's really a place that you don't get the care you need. In addition, private hospital beds are also getting very full. In case you think why we can't use them, you know, many of them are 50, 60, 70% occupied right now. Notice that when they gave us this number, here's the number for 5th of July, 917 ICU beds. Recognize that's not the real ICU numbers. The real ICU beds are much higher. This was data from our Director General of Health, and they have confirmed and suspected. They only give us the confirmed ones. They don't tell you the suspected COVID patients which are being ventilated. So you can see our real number of ventilation every day is much higher, usually 200 to 300 higher than the number quoted to the general public. So we're actually burning all our ICU beds. You may use this one to say our ICU beds are 95 or 99% filled, but when you use this one, the 1224, then you know we actually gone past the total ICU bed capacity in the whole country at the present moment. So this is what an ICU bed looks like for those of you who haven't worked. I mean, I've set up pediatric ICUs in my time. I set up the first one in Perak for children and then went on to do more. And an ICU bed is an expensive thing. We've got a specialized bed. We've got phenomenal equipment. We've got a ventilator to ventilate you. The ventilator alone may cost between 150 to 200,000 Malaysian ringgit. Then we've got lots of other ancillary equipment. So this bed actually may cost 1 to 2 million ringgit to set up if you want a really good bed. But the most important thing in this bed is these people here. It's your doctors, your nurses, your medical assistants, your pharmacists, the therapists who come, and they are there all the time. That's what an ICU bed right now. So when ICU beds are full, you don't get this kind of people, you don't get kind of equipment, then mortality is going to go up. So in a general ward, you may have one nurse looking after 8 people. So there's no way that ventilator patient is going to get adequate. You may actually, take some of these people from the main ICU and spread them around, which they have done, but means that care in the main ICU also drops, while care in the other place is still suboptimal. So that's why mortality has gone up in our country. Yeah? Okay. And you've seen the recent articles. I mean, many of us have known this for a couple of weeks, but not able to speak. One problem, many of my colleagues in the country would love to actually tell you more what's happening, but we're limited by, MOH, government gag orders. But people have started to say things that their emergency departments are really full. People have started to say things like, we've got hundreds waiting in the quarantine center, wanting to go to hospital. And these are people in stage 4. For COVID, there's stage 1, 2, 3, 4, 5. By 3, you need some oxygen. By 4, you should be in ICU. By 5th stage, you're on a ventilator. So people on stage 4, quite ill, waiting to be transferred, but can't because there's no space. 100 people waiting in ICU for an emergency bed. People having procedures done on the floor because there's no more ICU bed. Huh? Okay, so this kind of data is slowly coming out, but if all my colleagues in the country could speak, maybe the horror of what they are facing might actually galvanize the public to actually be a bit more careful about our situation. Okay, so looking at deaths, here's our cumulative deaths. Again, what I've done is I've divided it into 500 death batches, and you can see the first 500 took us about a year. But right now, we're taking 7 days to get 500. Can you imagine that difference? Huh? It took us 1 whole year to get 500 COVID deaths, but now 500 people are dying from COVID-19 every 7 days. And our mortality has gone up. It was previously 0.4% of people who get ill die. Now it's 1.3%. This weekly things that I've been calculating, I calculate the weekly mortality is 1.3% of people who die currently. So that's a big difference. Huh? We're losing almost 3 times as many people as we did at the beginning of the pandemic. That's because we don't have kind of optimal care anymore. So one other reason besides the ICU being full is because the numbers are so many, doctors are forced to triage the seriously ill people. I don't like this. I've never liked this. I've had to do this many times in my life for tiny preterm babies because we never have enough beds. You must recognize that we have never developed our intensive care, both for children and adults in the country, adequately in the civil service ever. We haven't really grown it adequately. Not from a lack of asking, people have asked. So right now, doctors, they make painful decisions. So they say, oh, you're 70 years old, you've got diabetes, you've got hypertension, your heart's not in good shape. Sorry, we'll send you to the general ward and give you a ventilator there. And you probably will die there very quickly, probably within a day or 2. And what we'll do is we'll take in the 40-year-old person who is quite ill with stage 5 or 4 COVID and put him in the ICU. So my colleagues are calling their workplaces war zones right now. They have extension beds everywhere. I hope some of you saw the video from Klang Hospital and the other one from Serdang. The one from Klang shows it very clearly. They have patients ventilated in general wards. And then some of my colleagues will say, they just tell the younger doctors, you just keep that gentleman in their district hospital. Don't send him to us because his outlook is poor. We won't ventilate him. So that kind of messages are being sent out. Okay. Some hospitals recently didn't even accept a patient because they're so full. So this is very, very painful, Dr. Smith. We don't like it, but you got to decide who you want to rescue, and they will probably take the ones that they can rescue better than the ones they think the mortality is very high. Even though I quote a 1.3% mortality right now for you, that mortality is not even across the ages. If you're older, you're more likely to die. You're younger, you're less likely to die. Even for me right now, I'm 62. I've got a long-standing cardiac problem. Been admitted to IGN many times. If I come to them, they probably say, Amar, I think probably general ward for you. That's probably what my situation is. So I want to tell you that this is something unpleasant, but happening. And so this is Italy, if you don't recognize it. This is where Italy was last year, where many people criticized them for doing this, but we're actually doing the exact same thing. Our intensive care overrun, and doctors have to pick and choose. And doctors who are not used to managing ICU, now managing ICU. Nurses who are not used to managing intensive care patients, forced to do so. And as I mentioned, one other rise in mortality is a non-COVID mortality. I don't like the word collateral at all, but that's a word used in the world. And people are waiting for ICU beds, often may die while waiting for ICU beds. IHME, if you search that abbreviation, it's an international health group, very good group. And it predicts for Malaysia that our total mortality will be 26,000 by September. That means they calculate both COVID and non-COVID mortality. They project for us. Okay. Actually, this number should be known to authorities. How many people die, without getting an ICU bed, and that actually should also be shared with us, not just the COVID beds. That will tell us the severity of our situation. So that's telling you that our mortality is going up, and we haven't reached the end of that up yet because the pandemic is changing. And let me talk about how it's changing. One is we're getting more people brought in dead. Secondly, what's not being shared with you very much is that people are also dying after leaving the ICU. The deaths I shared with you are COVID-19 people who die while either brought in dead or die while in hospital. But those who leave the ICU may also die in the few weeks after the ICU because their lungs and hearts are damaged. And we have a change in the demography of who is, dying or getting very ill in the pandemic. And I'll show you some data. Long COVID is something not in the psyche very much of the average Malaysian. I think you must read and think a lot more about long COVID. This is what worries all the doctors more than the deaths. And of course, variants are our current concern. So here's looking at just this last month, plus the first week of July at our deaths every day, the bars. And we are actually now averaging at 3.3 deaths an hour. That's another way to look at how our deaths are. Okay. Now, if I add on top of that, those who are brought in dead, these are the percentage of the deaths brought in dead. You can see that on some days it's 20%, most days it's 15 or 10%. So on the average for this whole period, 10.8% of all our deaths are brought in dead. This is unpleasant. This is no good. We need to understand why. At present, we still don't have enough data to understand why. Are these people who did not know they were COVID positive and then they died at home? Are these people who were tested positive and then told, hey, you wait at home first, huh? Uncle, the quarantine center is very full and we can't take you in yet, Or maybe it's an uncle or auntie or grandpa or grandma who's actually reaching stage 3 or 4, but the services are overwhelmed and cannot bring them in. We don't know any of this data. It's not available to us. But to lose 10% plus almost 11% of our deaths from brought in dead suggests to us that the system is failed across the board and no longer can be responsive to what's happening. Oops, I'm not sure how I did that, assuming. Never mind. Can I get rid of it, you think? Okay, good. It's gone. All right. So let's summarize that for you again. For the demographics, what's happening? Male, female is 60-40. We know men is always the weaker sex. Men, we know that, huh? Women have always been stronger than us. I've seen that from my time in pediatrics. Huh? So about 60-40, but recognize women still do die as well. Notice this thing here, known community. These are people without any chronic illness at all. So although you may think in your mind it's older people with chronic things, notice that it's almost 16% of people who are healthy individuals. No hypertension, no diabetes, no nothing. And notice that 33% are under 60, they're young people. So now we're seeing 30-year-olds, 40-year-olds dying, especially in this last couple of months. And notice that almost 46% of all our deaths so far have just occurred in June alone. So that tells you the volume and size. As I said, we don't know how many are dying after leaving hospital, and our crude estimate is that 10% of those who are rescued after leaving ICU die. And we don't have any idea of the collateral deaths at all. So here's the kind of people that we worry about today. There's a 29-year-old younger gentleman, well, no problem at all, got COVID-19 from the community, came in straight away at stage 5, very ill. Look at his lungs in bad shape. The one on the right is a normal chest x-ray for you to look at. So the one on the left is the gentleman with the COVID. COVID-19 doesn't just attack your lungs and give you pneumonia, it attacks your vascular system, your blood vessels. So it attacks your brain, attacks your heart, attacks the vascular system in the lungs as well. And this gentleman died very soon after this x-ray was taken. Okay? And that's the kind of deaths that bother all my colleagues right now. It frightens them that this is happening. And these people are not yet vaccinated, of course. The other thing that worries us, has been worrying us for the last 6 to 9 months, is long COVID. Now, what is long COVID? Long COVID is something that affects you even after the COVID is over. It doesn't seem to pick between severely ill and mild infection. It doesn't pick between old and young people. How common it is? Internationally, they're quoting 10 to 30%. I think the data still needs to be cleaned up. I'm usually quoting only 10%. And long COVID are people who 6 weeks, 12 weeks, 3 months, 6 months later still cannot get back to normality. They have something called brain fog, some of them. They can't think. Previously, they're scientists. Now they can't even write an article. Previously, they're doctor. They cannot go back to work. Some of them, their organs are damaged. Their lungs are damaged. So they can't even walk across the room. They can't jog for 5 minutes. Okay. And this can persist for mild. It can be mild or incapacitated. Even children are affected by long COVID. The estimate for children in the UK is 1 in 12 children who are infected gets long COVID. But I'd like you to remember there's 10% of at least of people. The only study we have for Malaysia is for people in ICU discharge who are ventilated. That's about 60% of them suffer from long COVID for that figure we have. Okay. So that's not very reassuring to us. So we are very worried about this. None of us want long COVID because it will incapacitate you for a long time. And we're not sure everybody will come out of this long COVID that you're in. And people are starting to get more data and looking how we can treat long COVID. The other issue that's topical right now is mutation spread. It's not new to us. In April, we saw the South African variant, now called Beta, in Kelantan and Ipoh. We had a cluster very near our home, very high rates, and that was the predominant variant. That's probably caused much of our third and our fourth wave, the initial fourth wave. But this is the one that we're worried about right now, is a Delta variant. This is the driver of our current tail end of our fourth wave and the current upsurge in our cases. Our problem is that very few genome testings in our country compared to our countries, even our region, Thailand or Singapore or even Vietnam, Cambodia do more genome testing than we do. But of the results that we have recently from the end of June, 72% of all the variants that are of concern are Delta variant. And Delta variant is very well known to take over. So in countries where it's come there, like UK or elsewhere, it's become the dominant variant, being 90% of all the COVID that's spreading. Okay, so Delta is not pleasant, and it's across the board. It's in many different states in the country. It's not just in the Klang Valley. You can see it's in Melaka, it's in Pahang, it's in Sabah, it's in Negeri Sembilan, Putrajaya. I think you can expect that it's in most states if we did enough genome testing. Okay, so what does the Delta variant do? The Alpha, which is not the original, the Alpha is the one from UK, is 50% more contagious than the original. The Delta is 60% more contagious than the Alpha. Let me try and illustrate it with a simple diagram. Here's the original Wuhan one that came from Wuhan. Then there's a Europe first wave that caused it. That's Alpha and that's Delta. So you can imagine that this one person can infect a lot of people. This is the RO number, if any of you remember that number. Okay, so one person can infect 5 to 8 people, which is phenomenal. Huh? Of course, not as severe as measles or mumps yet, but still a very frightening thing. Okay, so it's becoming dominant. We're not fully sure, is it more severe? There is suggestion it's more severe. Is it resistant to vaccines? The UK data suggests that this is one dose of Pfizer AstraZeneca is not enough. You need 2 doses. There's a slight drop, but I just saw data from Israel, which they confirmed this morning, saying that for Pfizer, there's a 30% drop in efficacy for Delta. So they're actually advocating that maybe the public should get a 3rd dose of Pfizer there. So these mutations like Delta are what can explain the higher numbers, the increased ICU beds, and perhaps why younger people are getting severely ill and why we have more brought-in death. People are not aware they're getting very ill very quickly. Of course, now, I also want to ask you to read about Lambda. And Lambda, they started in Peru, is now spread to many countries in the world. I think even Australia has had a lambda despite the tighter control that they have. And I think we need to look out for this because this is said to be far more infectious than Delta. So what is Delta doing? Let's say in the UK, for example, here's cases, they had settled actually. Now their cases have gone up. But the hospital beds going up, but not as fast. We need to see the mortality data, okay? Whether it goes up. Because, this diagram some of you may have seen, we're not expecting the vaccines to stop all infections. We want the vaccine to prevent severe infection or hospitalization. Of course, the ultimate is the vaccine can prevent death. We're very happy. But I would like it to stop here at hospitalization. So the data for the Delta is still unclear. I think you should look at Israel's and UK data. Frequently, UK says within a week they should be clearer. The scientists say, the government of course wants to open up. The scientists say don't open up because they're not happy with what's happening. So we don't really know whether Delta is going to make their vaccination program in a country like UK, which got 50% at least vaccinated, whether this is going to be sufficient or not. So many people are saying because the RO for Delta is so infectious, you need maybe 70–80% of the population to be vaccinated before you can stop the Delta from spreading in the community. So next thing to ask is how's our vaccination progress? And plus, I might say a word about side effects and choice of vaccine, which is in everybody's minds. I think a lot of WhatsApp messages are about concerns about this vaccine or that vaccine and so on. So here's a graph looking at our vaccine progress. Initially, we had a very slow start, mainly due to supply. It took us 72 days to reach 1 million people, but then we have accelerated. This is a target that we need to reach, which we have reached in the last couple of weeks, which I'm very pleased with. We have reached 1 million new people. Remember, this is first dose only. 1 million new people vaccinated every 7 days. Of course, Amar is greedy. He would like to double this. Everything is supply game. Everything is how much we've got. But this is a very commendable thing that we've reached 1 million new vaccinated people every 7 days. Okay, that means that we are making good progress right now. And we need to maintain this every day. We can't afford to drop on a Saturday or Sunday. Okay, and of course, we've got enough supply on paper, but whether it's reaching us, I'll talk about in a moment. So currently, 20% of our population has got 1 dose and about 8% have got 2 doses. Okay, so here's comparing us with others in case you needed this comparison. Again, data is very easy to manipulate. I'm a researcher. I ran a research department for many years, and I can just show you the worst countries compared to Malaysia, then we look good. I picked and chose. I chose one of our good neighbors. I chose some of our nearby neighbors. I chose Japan, and I put the world data there. I didn't choose Europe, and I didn't choose the US or UK because they're far ahead of us. I don't want to compare with them. Okay, so we are better than Indonesia, Thailand, and Vietnam. I'm very disappointed with Vietnam. I can't understand why this is happening. People also can't understand because Vietnam is definitely far ahead of us in healthcare. Okay, Vietnam and Taiwan are the people to look at actually. So in terms of the world, we're slightly inferior, but Japan is picking up slow though. We're also not impressed with Japan. But look at Cambodia. Wow, impressive. South Korea, pushing the 1 dose very strongly. I think we have to reconsider this in view of Delta. They may have to start mopping up the 2nd dose. And Singapore, of course, trying to accelerate their 2nd dose right now very quickly because of Delta spreading. The predominant variant in Singapore is Delta right now. So that tells you we are there, and I suspect that we will make more inroads further. Here's the vaccine supply coming to us in July, and you can see that's pretty good supply coming in July. But remember, it's coming in July, so we will slowly ramp up. And so probably by end of July, we're going to see a sizable jump in our vaccine. And my desire of seeing 2 million a day is probably a week. New people just might come true. But of course, that's a big push right now to try and accelerate the 2nd dose vaccination for individual because of Delta and all the data we know about Delta. Having said that, I must point out to you what they're not telling us, which is vaccine distribution is not equitable in Malaysia. There's been a lot of noise, even by our authorities, to say vaccine supply in the world is not equitable and all countries must get good supply. I agree with that fully, but I would like to say the same applies to our country. Vaccine supply must be equitable. I have got better numbers than you, but I apologize, I'm not able to show them to you. I can track to you when supply is going to go for the next few months and which state is going to get to you, but that was a leaked document. I'm not in position to share it with you. But the current situation, you can see that Putrajaya, Labuan, KL, Sarawak are far ahead, not because they're doing better. I can tell you that the Ministry of Health staff on the ground are superb individuals. I've worked on vaccination for a big part of my life. I brought in measles, mumps, rubella vaccine, MMR, and I brought in HIP for the country. It was 4 years of my life's work with colleagues, and I helped to revamp our childhood vaccination program. So I know the strength of our vaccination team. They're superb on the ground. They can do it. So any state you give vaccine, they will achieve this. I can tell you that. The problem is supply. So you can see this big disparity. So I can tell you that Sarawak, Wilayah, Labuan are going to reach in August, between 60 to 70% vaccination rates, which is wonderful. Okay, I'm talking here about total population, not adult population. You can look at here in KL, they claim 88% adult population vaccination already for 1 dose. But total vaccination population by August, definitely 70-80% for these states. And probably Selangor, which is getting a huge injection of vaccine right now because of complaints from the royalty there, is also going to go up. But the rest of us, we are going to be dragging. Now, I don't begrudge you. Many of you I know are probably in the Klang Valley listening, and I don't begrudge you this vaccine. And I recognize that there is some need to boost vaccine. But I think Sarawak is doing it purely because they want to have an election, which I don't think anybody would condone in this climate. I don't think election actually can be safely held. Many of my colleagues would believe that as well. And Labuan is in a crisis. So Wilayah, Labuan, Selangor should get a bit, but I think we should push vaccine to the other states so that we don't end up becoming like the Klang Valley, which can happen very easily with Delta. Okay. I moved into phase 2 in Perak, which means there's some opening, very rapidly things can escalate if people let down their guard. So are we going to reach herd immunity? I know this word is not so popular anymore, but I still think it's a valuable word to look at. This is a graph looking at 32 million population that we know about. And, we need to mop up this vulnerable 7%, 65. Right now, there's still almost 1.9 million people in this category not vaccinated. Let me tell you that. Partly because they don't know how to register, some of them from Sabah and so on. And we're still not targeting them adequately. They're supposed to have finished, but we have not. And again, there is a population here that I did not show of people with comorbids, with hypertension, diabetes, and all who should be mopped up. We've got citizens, and I've conservatively put non-citizens, 10%. Is definitely much higher than this. We've got some people who are definitely not ever going to get the vaccine because they're not fit for it. And there's probably at least 10% who are not going to get vaccinated, maybe higher. And there's 30% children under 18. So you can see, just looking at this figure, if we need to reach 70%, we are not going to get there without looking at children as well. So as a pediatrician, I'm not keen to vaccinate children. As a person looking at the global picture for Malaysia, we will have to vaccinate children if we're going to stem this. But let's finish off all these adults, finish off and try and convert. Of course, non-citizens must be vaccinated quickly. And we try and persuade some of our colleagues who are not vaccinated, some of our church members who are not keen for vaccination to change their minds and come. Then perhaps we start looking at children. And with this big concern about side effects, I can do a whole talk on side effects and give you details, but let's just summarize it. All vaccines have side effects. Common ones, very common. Severe ones, sure. And what is the common severe side effect? The rare severe side effect is anaphylaxis, which means an allergic reaction. This can happen with anything in your life. You can eat a new food and have an allergic reaction for that matter, a new perfume. So with anaphylaxis, with these vaccines that we're using, it's about 1 in 100,000. We don't know who's going to get it, but we can predict somebody with more allergies more likely to get it. Okay, and generally they try to do this people in hospital to protect them. But what about the two currently most used vaccines in the world, Pfizer and AstraZeneca, or the three most used, Sinovac as well? Pfizer causes myocarditis. This is well recognized now. Okay, and I can give you numbers if you need. If you take all the numbers, it doesn't look so high. It looks like something like 1 in 200,000. But when you take young people, like if you take the US data for people under 30, then it looks 1 in about 30,000. When you take even younger from the Israeli data for children, 12 to 18, then it's 1 in 3,000, 1 in 6,000, which is pretty high rate, which has made many of us have a pause about, rethinking about vaccinating children with this vaccine, and we need more data for this. AstraZeneca, we know the thrombosis risk is uncommon in older people. So someone like Suming or me, our risk is probably close to about 1 in 500,000 or 1 in a million chance of getting a blood clot in the brain. But once you're 30 years old, your risk is probably 1 in 100,000 or maybe a slightly lower. So I think you're going to rethink, which is why many people are not giving AstraZeneca to people under 30 and prefer using the Pfizer. Again, must think of the myocarditis risk. Sinovac data has always been weak. They, of course, have given better data to regulatory authorities, to our drug authority and others, but that data has not been open source to the public. And in countries which are using Sinovac, we haven't really seen the side effect data adequately, and we like to see that. So I can't make very many comments about this. These two have very, very good data appearing from many countries. Okay, so I can come back and talk more about this if people need to. So what's going to happen? What is possibly going to happen? Why has all this happened? And as I said, think about the fifth wave. So we have reached Italy. We have been actually for a couple of weeks right now. I don't want us to head for India. And by the way, you know, if you look at Peru and other countries, some of the South American countries like Peru are 9 times worse than where India was. I can't even imagine that India was so bad, but these countries are very, very much worse. And I don't want to end up there. And it's possible for us to go there, by the way. So it's happening because, as I said, we have limited testing. It's going to take time to reach 50% of the whole population. Okay, minimum is going to be 3 to 4 months. So you're looking at October, when you can think that 50% of the Malaysian population in every state is going to be 50% at least, 2 doses, not 1 dose here. Huh? With Delta, I don't talk 1 dose anymore, we talk 2 doses. The Delta mutation is the one to worry about, and of course, Lambda will be coming behind that. We need to think that, you know, there's a lot of pandemic fatigue from our public and SOP confusion. Even yesterday, I was discussing on Twitter online with people, they're so confused. You know, I have to give suggestions of what the SOP is looking like, but that should come from our authorities, clearer and, you know, standard SOPs that don't change too quickly. And we know that support for those who are severely affected during the lockdown is very inadequate, and these people are struggling. There's a very high suicide rate now. Our suicide rate is double this year, by the way, in case you need to know. From the suicides that we know, the suicide rate is double. And a lot of people are in malnutrition. I worry about all the children who are in malnutrition right now in many places. So don't depend on lockdowns and vaccines. That seems to be the Malaysian solution right now. We have put all our eggs into one basket, which is the vaccination will save us. And we're using lockdowns to buy time. But the lockdown, how long? The lockdown can't last 3 months, can it? That's the time we need for our vaccination to come. I'm being very conservative here. It's probably going to be 4 months. You know, if I were the authorities right now, I would take every health person I can get, take every dose of vaccine and put it in every arm. Any one time, there are probably 2 million doses of vaccine sitting in the store, and I would like to get them into the arms of people, to move them out very quickly, improve our logistics, take every health person that we can and jab it. Okay, and we don't know what the variants are going to do, so don't put all our eggs in the vaccine basket, and don't depend on lockdowns to buy time. Here's the WHO, World Health Authority, infectious diseases epidemiologist Maria, who, you know, very, very good, worth listening to her. She'll be on YouTube, and you can find her through WHO or other means. And here's one of her tweets yesterday. You know, public health measures, she says, does not mean lockdown. WHO doesn't advocate lockdown. It means having policies in place to reduce risk every day. What does this mean? We test, we do surveillance. Surveillance means we go and chase all the fellas. Contact tracing, we need to do that very vigilantly. And testing, WHO says, you don't go and test the average asymptomatic person in the community. You know, sorry, I've done that again with the mouse. You go and test, you know, the people who are the contacts of the fellow who's found positive. And you need to support health workers. You need to have adequate oxygen. You need to improve ventilation, something that I'll come to in a moment. And you need to get vaccination if you can. Okay. So here's why I talk about the fifth wave. It only took 4 weeks for us to move from third wave to fourth wave. Now we look like we might be already. I wrote an article when we were here, somewhere about here, but I anticipated this already coming for a number of reasons. You read the article, you can just find fifth wave Amar and you'll find it. And this has only been 2 weeks, by the way, for this to go. You can actually say it's part of the fourth wave. I have no quibbles with you. We settled a little bit and then, you know, it's gone back up. And I do not know where this is going. Okay, definitely can go a lot higher than we are. Right? So as I said in the article, I was worried that it would take off from the plateau of the fourth wave, which it has. So right now, what's going to happen is our already happening quarantine centers overflow. So we have to push more and more to home quarantine, and that's going to grow increasingly. And that's someplace the church should look at. We're going to run out of ICU beds. Already, we're actually running out of ICU beds right now. Are we going to run out of oxygen? No, we won't run out of oxygen, but we run out of oxygen delivery is possible. India never ran out of oxygen. They ran out of oxygen delivery capacity. They couldn't deliver the oxygen they had to people. They didn't have enough cylinders, didn't have pipe oxygen in the hospital, didn't have oxygen concentrators. But they had stored oxygen in the companies, but they couldn't get it to the people. And of course, we can recognize the increased community frustration, unrest. And one of the concerns I have, is that this unrest mustn't spill over, because that's not healthy for us at that time, to spread COVID. In case you think it's just me thinking this way, many articles right now out there talking about Malaysia is one of those countries that they talk about going to have an oxygen crisis in the near future. So let's talk about what we can do. And I haven't put everything inside, and I know there's some medical colleagues in the audience. Swimming is here, and we can bounce ideas off each other. My wife is also here as well, and we can bounce ideas what the church can may be able to do. But these are the key things I think you should do. The key is to don't get infected. Sounds simple, huh? But that's the key to do. I think if we all can actually emphasize this as much as possible, and the poor are the ones who have difficulty emphasizing this because of cari makan and the struggles that they're in right now. And of course, there's some people who don't believe COVID is a problem. I wish they could come to the COVID ward, and work there for a week. I think they will be transformed. So limit all unnecessary contact with people, work from home, online education for children, improve the quality and fit for your mask, get vaccinated the moment you have a chance, focus on ventilation, maintain your personal fitness, and support others. And let me enlarge on each of this very briefly. So there is no safe number. Huh? Don't think that a small group of 20 can meet. Don't think that somebody in the church of 50 can meet. No, there is no safe number right now. Just think that way. So you've got to maintain a home safety bubble, which means these are the people you meet every day in your home. These are the ones you trust. If you see your neighbors, when you're jogging by the side of the road, which you're allowed to jog by the roadside, you wave to them. You don't stop and talk. I still see some of my neighbors talking to each other every day, and I am frightened for them. That's actually a very, very bad thing to do. Okay, so don't interact with anybody in your neighbor. You wave to them. You don't talk to your neighbor, you give them a video call and talk to them. So there's no safe number. You want to buy food, you buy from shops that give you an opportunity to buy from the edge if possible. You try not to walk in the shops. You scan from the outside, then you go and give you a container, they tap out for you and you come back. All restaurants should actually go and do that. Some of the restaurants I like, my wife like, they've done that. They've pushed a counter to the edge, the door, and you can just order there and buy it from there. Okay, so don't keep a very strong home safety bubble. Secondly, we must have a work safety bubble if you go to work. But ideally, everybody should work from home as much as possible. But if you need to go to work, and some people do need to go to work, you need a work safety bubble, which means two things to me. One is people must be honest. I call it a trust bubble. You tell everybody the moment you had contact with somebody, if you're infected or you are anyway unwell, you don't come to work, of course, immediately. But there's one more thing that we should start doing. We should start testing people. In many countries, you look at Singapore, many countries in the world, the UK has been doing it for some time. They offer you rapid antigen tests, things that you can do yourself at home, okay, very quickly. So in UK, they're doing once every 4 days. But I think routine weekly testing is the way to go. If we have not enough money, do 2 weekly first, then go to weekly. This can be done if the authorities actually vet the tests, choose the good ones, and sell them cheap. In Singapore right now, it's 10 Sing dollars that you can buy in the pharmacy for this test, which I think is not very prohibitive for many individuals to do. Okay, of course, the problem comes when you're positive. What do you do? Some people may try to hide it. No, you're positive, you tell people, okay, and definitely you quarantine at home until people have decided what to do. So there's no safe number at work. But some other tips for you, which I've noticed that people are not doing. Don't eat lunch together at work, because that's when you unmask. Bring a tapao lunch, sandwich or something, eat in a quiet spot. Okay, don't eat near other people. Don't unmask in the toilet at work. It's very poor ventilation site. That's where you must keep your thing and clean your hands properly when you're there. And if you are in a bus transport, if any of you got friends who are migrant workers or others who are transported in a bus, that's a very high risk place. In a bus, people tend to chat, sit together, might even bring their mask down. I don't like children not going to school. I'm a pediatrician. I want children to go to school. They are suffering. Psychological trauma in children is very huge in our country. I've done some talks on this about the mental stress on children and how we can build some resilience in them. And school also allows the poor to come back. It gives them some childcare, allows the parents to go to work. It gives food. There's a food program in our government schools that can give food. But very, very risky is my opinion right now. And so we had to do online classes. But the problem is that, 40% of children don't have digital devices. So one of the things the church should do is, please consider looking after the poorer communities and give away devices. I never thought that I would say at time, give devices to children. I've always been one who says, don't give screens to children until they're older. Now I'm saying, for their continued education, they need the screens. Even if they surf the internet, I'm fine, because at least they're learning something and they've got some distraction that they can grow in. Huh? And, give away all devices, but also think about Chromebooks. We're not a Chromebook country, which is very sad. Chromebooks are the cheapest, most versatile device that I just start up. You open a Chromebook and use it. There's nothing else required for it. Huh? Now, there's a group of people in the country that are going to come up with a statement in the next couple of days saying we recommend that open schools straight away and we don't worry about lockdown for schools. I have decided not to sign that letter. I do not agree with that data. Okay, I think that children are a risk to spread to other individuals, and schools are a place where there's no herd immunity right now. And children can come home and give it to their family members. So I don't support this at present moment, open schools. But I know the difficulty of online classes. I know how the dropout rate is very high and children get fatigued with online. Even me, doing a Zoom session also fatigues me. Okay. Fourthly, think about the quality and the fit of your mask. Not just the mask, but quality and fit of your mask. Okay, so focus on quality, your filtration capacity. How good is your mask? And focus on a good fit, minimal leak. And if you're using a surgical mask, do this with your mask. It's not enough to wear a surgical mask. Do this as the Center for Disease Control in the US says, or do this, which is your surgical mask inside and a cloth mask outside. And if you're using a cloth mask, which I'm perfectly happy with, if you're using a cloth mask, have a good quality mask, follow the WHO recommendations, 3 layers, one outside that repels water, one inside that, one inside that's hydrophilic, one outside the hydrophobic, and inside of maybe another filter that you can put in, okay, and do that. So do this. Here's me and my wife. Here's me. I wear a very high quality filtration mask, which is almost like an N95 mask, which I buy from South Korea, available in Malaysia. It can be reused about 7 to 10 times with an alcohol spray. And I use a face shield routinely. I'm double vaccinated. Despite double vaccination, I'm still doing something like this. So anybody who's vaccinated still needs to maintain normal COVID-19 prevention measures, okay? Because of the new variants coming, until we know a lot more in the next couple of weeks. Not the time to drop your vigilance, okay? And think about improving the quality of your mask. Don't do this at all. Went to do a blood test on Monday with my wife in the BP lab. The guy behind me was doing this. I had to tell him, please put up your mask, uncle. Sometimes I think people call me uncle nowadays because I'm old, but he looked a bit older, so I call him uncle. And thank God he agreed, he could have kicked up a fuss. And don't touch your mask ever, Somehow children can learn this, but adults seem to be very poor at doing this. Fifthly, don't pass up any vaccine opportunity. Don't be vaccinated, grab the vaccine, okay? What's going to happen to us if we don't grab the vaccine? This is data from last year, published from Malaysia in an international journal. For 100 people who are infected with COVID, 8 become severe, 3 get ventilated, 0.5 to 1% die. This is the best of times, okay, friends? This is not true anymore. Huh? If you're older, like some of the people in the audience, this is not yours. Yours is much higher of all of this. And don't forget, the 10% long COVID. So, if you get COVID, your risk is so much higher than the vaccination risk is what I'm trying to get here. And here's the risk trying to express to you in a diagram. This small dot here is the side effect that everybody is talking about in the WhatsApp group. I can't make it any smaller, I'm sorry. Are you going to get a severe side effect? Some people, yes. Some people are going to get a severe side effect. It's small, okay? The younger you are, the higher the chance of this side effect, sadly. Are some people going to die from a vaccine? Yes, I'm not a person going to lie to you. Rare. Maybe 1 in a million, 1 in 2 million people just might die from the vaccination. But these are the size of the people who are going to die from COVID-19. I didn't make that big enough. I should make it bigger in the current phase. It's gone past 1%, 1.3% right now. And here are the people who are going to die because we haven't controlled the pandemic and they can't get healthcare. They need the other ill ones. And here, the big one here, the long COVID. If you get COVID, you might be lying in bed or not able to function, not able to work for months, and we don't know whether that's reversible in everybody. And finally, this is what all of you and I are feeling, the complete disruption of our lives, the education of our children, and the increased suicide and so on. So, while you are worried about this, I am worried about all of these as well. And I think you should also think about that. Okay. and make a decision. Don't pass up a vaccination the moment you have a chance. Okay. 6, focus on ventilation. We used to focus on surfaces, but we know very clearly the vaccine is airborne. Airborne is not droplet sprayed. It's like a smoke spreading. It's like when somebody's, smokes a cigarette or vapor and that vapes and then comes out. It can go very far. And we know that indoor, it's pointless. 1 to 2 meters is meaningless indoor. Okay, just think about that. You put chairs apart in the church 1 to 2 meters. You come together for your song practice 1 to 2 meters. It is meaningless in the church setting. Okay, so you need to improve ventilation if you have to go to work. So these are essential people who need to go to work right now. You need fresh air exchange. Stop your aircon if you can, unless your aircon has got a HEPA filter that doesn't recirculate the bugs. Open the doors and windows. Avoid a draft across the room. Stick a fan at the window or the door to suck air out of that room. Keep your toilet exhaust fans out. And long term, we need to read. Please read about HEPA filters. Read about changing the ventilation in the room. Long term, we should actually renovate some of our smaller rooms and offices. Even our churches perhaps. To do this. Our hospitals definitely to improve ventilation. By the way, the average aircon recirculates 70% of the air. Remember that, huh? So that's not good. These viral particles will just be coming back again to you. Having said that, the Malaysians have very poor airspace thing. This is outside the vaccine center in Ipoh when there was a rush for vaccine when the wave went up. I mean, I would never get near anybody like this. Don't, okay? Get people to distance even outdoors. Outdoors is a lot safer, but you must have the concept of airspace of 1 to 2 meters from people even outdoors. All right. 8thly, maintain your physical, emotional, spiritual, mental fitness and grow it. Don't just maintain it. Time to grow. Time to get closer to Jesus. Time to grow our spiritual, strength and well-being. Time to trust the Lord in a way like we have never trusted before. Time to dwell in the eternal embrace of our Father, isn't it? Nature is very important to me. God speaks through me through nature intensely. These are just some birds in our garden, not outside, not anywhere in the jungle, just our garden. Our garden is very green, it's a wild garden. And of course, I often look at everything, and there are wildflowers in the garden as well. And there's a lot of beauty that we can see. And in case you're struggling, turn off your screen, stop reading about COVID all the time, then go and just take a deep breath, sit some time, be still and know that I am God, and do that with God as much as you can. Finally, share our resources, please help others. My wife and I have done this extensively in this last 1.5 years. We've always been sharing resources, but never like this before. So one thing you can do is try and adopt some poorer families that you may know about and tell them, okay, you're going to get this fixed sum coming to you every month from us, and for the next maybe 6 months or 9 months, so they know. You can give away. I think Swimming is doing food coupons, but my wife and I do ang paos. Everybody that we meet gets ang pao. Yesterday I went to Tapao. On the way back, I passed by a stall. I didn't buy food from that stall, but I saw them struggling, so stopped and gave them 2 ang paos. Ang paos are sizable, by the way. They're not small ang paos. Okay. Pay more for your meals. Every meal or any service we pay. We pay double. Okay. And people are so shy in the beginning. This Chinese, food stall, so shy to receive from me. Now, no, they just take because they're desperate. Their business has crashed by 50 to 80%. They're struggling. Okay. Hire jobless individuals. The young people who have lost a job, hire them. Time to actually, you need IT, online needs for your church. And some of these young people are far better than us. Hire them and use them as your IT consultants. They may not be IT specialists, but they definitely know how to tweak the systems better than us. And of course, work with disaster organizations like Swimmings. And here's Crest that I want to show you their front page. They're giving money away, and notice that they're struggling, okay? They give away more than they receive. Hey, give them some money, Swimming didn't ask me to do this, by the way. He doesn't know I'm doing this. So please throw some money at them. They need money desperately. And that's what I'm doing, my wife doing. We find an NGO that's struggling, we just throw money at them. Yet a couple of days ago, we found one in Perak that we regularly support, really struggling. So I called up all my doctor friends and others and say, hey, give money. And so of course they all give. Everybody give a little bit. We can get the NGO back up and running, giving food. This is giving food down to the ground for people who are hungry. Okay. Now, these are some things that are in the document that I wrote, but some things that maybe the church wants to consider. I don't recommend this for individuals. We need to think about oxygen delivery to people right now as the situation worsens. I pray and trust that all that I'm saying right now is useless, that we will do this and it's of no value. Then we will laugh about it, say, Amar, see, no need to do. I would love that to happen. But If we don't do this and it happens, we are going to be like India, scrambling, and people are going to be dying in their homes. So we need to invest in oxygen concentrators. Now, don't invest in oxygen tanks. They drain very quickly and they have to refill. It's an expensive business. Oxygen concentrators are things to do. They're not so easy to get. Many of us been working. I had a talk with the Sarawak churches a couple of weeks ago. Swimming organized one with and we did one with the pastors in the Klang Valley. Elisha from NECF organized that. And so people have been buying up. I have a support group for Ipoh Hospital consisting of doctors and led by our former Deputy Health Minister, Lee Boon Chai, and we've also been buying, lots of people have been buying. Now, when you buy an oxygen concentrator, buy the slightly better quality one. Don't buy the one that has to be recharged intermittently. When you have to recharge intermittently, this guy cannot receive oxygen during that period. They're that kind of it. Don't buy those. Buy the one that when you're recharging or plugging in, he or she can still get the oxygen delivery. Huh? Maybe a bit noisy, but this we can give to the home. And we need to devise a system, how to deliver them at home, how to monitor them at home. Who's going to do that? And your churches have many doctors. The Methodist churches have many doctors. Some of them retired, some of them not retired. They can actually do a video call with these people. One thing we need is a pulse oximeter. It's something that many people should buy. Even you, those of you who are not ill, should consider buying a pulse oximeter. I've given you some brands that may be better brands. Okay. Remember that the saturation is low, less than 90%. Please go and test it again, or test it on your wife or your son or daughter, because it may just be your finger or the monitor. Huh? Okay. So I noticed that it can be glitchy a little bit, but it gives you a trend. So if we are going to do home oxygen monitor support for people, we will need monitoring, and the pulse oximeter is one of the good monitors that we can use. So I believe that one of the things the church should do right now is start to work with disaster organizations to develop locations where we can house individuals. Not everybody can do home quarantine. Some people might need to be quarantined in somebody else's home. Maybe you got a large house and you have an outhouse with a separate kitchen and toilet. You can ask people to come and stay there. Or maybe your church has got premises for people to come in and stay that could be used as well. You have some dormitory facilities. And these are not just Malaysians. These are all people, including our migrant workers as well. Okay, so I think we should start developing right now. Swimming can say a lot more on this because he's been working on this, and he can talk about the regulatory requirements from Ministry of Health and MKN and other things like that as well. As I said, I've not covered vaccination, but happy to do that with you if you need to. I'm going to stop sharing here and take questions from everybody right now. Back to you.